Welcome to everyone who's joining. This is meant to be predominantly a question and answer discussion, and there's going to be another session later this week on HIV and methamphetamine. But just to kick it off, I thought I'd throw out a couple slides just to make sure we've got something to talk about. And so hopefully everyone can see my screen. If not, I hope someone yells at me. So one of the things just to remind everyone is that methamphetamines do actually do something structurally damaging to the brain. And here's a picture of brain comparison of someone who's addicted to methamphetamines compared to someone with Alzheimer's. And the red is an area of volume loss. And so some of the things that are highlighted, I don't know if my little pointer works. So at the bottom here, this is the hippocampus, and that's memory. And over here, you can see one of the things that, we talk a lot about how memory is impaired in Alzheimer's disease, but you can see the volume loss that's happening in the hippocampus as a result of methamphetamine addiction. And the reason this is important is because one of the predominant treatment mechanisms for substances of use is things like cognitive behavioral therapy. It's things that actually require memory. Methamphetamines can also do other things. They can impact motor. So you can see over here, is the top is a normal control, and down here is a methamphetamine user. You can see the loss, the red up here, which is lost down here, is a loss of dopamine receptors. And so you see a reduction in dopamine transportation that results in a slowing of motor. And as already mentioned, we see a slowing in memory tasks. We know that not just methamphetamines, but stimulants in general actually increase viral replication. One interesting thing about methamphetamine is that it not only increases viral replication, but it increases expression of CCR5 on macrophages. And so some of this is potentially thought to be contributory to the immunopathogenesis of people with HIV who use methamphetamines. Obviously, a reduced neurocognitive performance is really devastating, as it not only affects HIV clinical care, it's going to affect adherence to therapy, which could result in resistance, but also is devastating just emotionally and to the well-being of the individual. Unfortunately, there's no pharmacologic treatment. This is a review from 2017. There was actually an updated review in 2020. Again, unfortunately, with no real pharmacologic agents that have demonstrated efficacy. There have been a bunch that show efficacy in very small groups, but as that you try to get a larger sample size, more patients, that effect tends to always go away. Behavioral therapy is still the mainstay of treatment. Motivational interviewing, getting people excited about treatment, and then trying to do something like CBT or NA or any kind of therapy that really helps the person to start thinking differently about drug abuse. Of course, this goes back to the earlier comment of memory. If you're struggling to remember, that becomes very problematic. These are medications that have been tried in the past. Again, all these slides will be available. We'll go over this again in the future, but these are meds that have been tried that don't work. This is a medication that is in trial right now. Had a promising smaller trial. The data is here. We always tell people to be wary though, as larger trials and all of the previous, actually smaller trials and all the previous drugs had showed efficacy, then in larger trials that went away. This is also one big issue. Is this is, as I mentioned, a small study now replicating the larger ones. Ongoing data is pending. Here's another medication. This is really trying to look at a stimulant as a possibility as an agonist therapy for methamphetamines. We'll talk on Wednesday about how opioid agonist treatment has actually been revolutionary. They continue to try to find similar types of things in the methamphetamine world and in cocaine. However, those have universally not been effective. This is one ongoing trial trying to see if a new stimulant is potentially different, has lower aberrant use risk, and potentially could be helpful to individuals. So that's kind of a quick 4 or 5 minutes on some things related to HIV and methamphetamines. And I think with that, I'm hoping that people have started to put stuff in the chat and we can start having a more general conversation about methamphetamines and HIV. So if you do have a question, type it in the chat or unmute yourself. Everyone was muted when they came into the discussion, but you can unmute yourself and ask your question, or feel free to type it into the chat. Otherwise, I can just talk about humorous anecdotes in the world of. So there's a great question for Maggie. Are there adherence strategies that you have found successful in the group of people using stimulants? So it's a fantastic question. So what I typically have done with stimulant users is tried to break down as much as possible their abuse patterns. So a classic example might be someone who uses cocaine or methamphetamine, somebody who's binging, say. You know, one of the things we've found is that people will use enough of these stimulants, they'll kind of have enough dopamine that they just have to stop. Like their binge has to stop. They have to take a break for a minute. So one of the things I would try to do is find things that are a consistent pattern in that person's life. So are you staying at the same place every day? Do you associate with the same people every day? What are you doing that's relatively consistent? Or one of the things we try to think about is, are there types of regimens that we can come up with that have a greater propensity to withstand some non-adherence? The most successful adherence strategy is always having an honest conversation with the person and determining the patterns of that person's life. And it's a huge issue. So a classic example was a patient of mine many years ago. This was a long time ago. He was taking adherence at night. And so he was just, we switched him to a PI for other reasons, but eventually he was taking his meds at night once a day. Then he started to drink at night and started to struggle with his adherence. And so we had to actually start having an honest conversation. He thought, oh, well, I have to, do this evening thing. Well, no, as I helped explain to him, we'll take the regimen and we'll structure the regimen around your life. That's always more successful. When you try to structure the life around the person, the medication, say, change your entire life in order to take these pills, that's less successful for drug users. Their life is already organized around the drug of not the HIV medication, but the drug of abuse. So now it's about, okay, what's your pattern of life? Let me take that and tailor your HIV therapy to that. One question that was also asked was around chemsex and the effects of HIV risk behaviors among MSM and heterosexual meth users. So we know that, this goes back to data a long time ago. There's actually a study that shows that if you drink 5 beers, you're less likely to wear a condom. So we find that there are two main reasons that people engage in drug use and with sex. So one is that there is a desire to increase sexual pleasure, right? And so that can lead people to do all kinds of things in relation to sex. We know that drugs impair judgment. And so sometimes people are using drugs, as I found in Malaysia, men who were having sex with men, it was a culturally taboo. And so they would use drugs to engage in sex. And then they could blame the drug use, that they're not men having sex with men, they're just men who use drugs. And well, when you use drugs, things happen. One of the big issues and concerns, obviously, is that when people's judgment is impaired, they will engage in greater risks. So you're less likely to wear a condom, you're more likely to have multiple sexual partners, you're more likely to forget taking your HIV therapy or your PrEP or other things because you're impaired as a user. And so that also becomes really important to help try to educate people. Your patients may not say, well, I'm going to give up sex, I'm going to give up drugs, but it may be possible to say, okay, well, is there a designated driver? Is there somebody that can go with you? Is there somebody that can watch over you? Somebody that can help you take care of your medications and protect yourself? A clarification was asked just relative to what does methamphetamines do relative to immunopathogenesis. So one of the things that happens both in methamphetamines and in cocaine use is that by increasing the viral load and upregulating CCR5, you see a more rapid drop of CD4 count. I used to, when I did HIV care in the jail system, before I met patients, I could look at the labs that they would get on intake into the jail, and I could pretty much guess, okay, this person's using cocaine, this person's using heroin. And I used to, test my theory by just seeing the patient say, I see you've been using cocaine. I say, gosh, like, how can you tell? And I say, well, your CD4 counts tanked, right? And your viral loads through the roof. It's not 100% all the time, but that's a common theme. So one of the other questions, a lot of patients use meth to go to work. It's really hard to counter that they claim their livelihood is dependent on meth use. What would I say to that? Well, this is something that happens oftentimes. So one question is kind of, what kind of work are they doing? Is it they're truck drivers and driving for 14 hours straight? Are they involved in the sex industry? So there are lots of reasons for people to say that their livelihood is dependent. I think oftentimes people are saying that because ultimately they are wanting to justify their use, right? And this happens a lot of times where people say, well, I have to use heroin because I have chronic back pain. I have to drink alcohol because I can't go to sleep. There's any number. I have to eat 6 bars of Xanax because I have an anxiety disorder. So patients have rationales. And so one of the things to try to do it is not to question the whole, okay, I don't believe you that your livelihood is dependent. We call those individuals pre-contemplative. And so what we do is we try to provide evidence that shows the harms. So I realize that you say that your livelihood is dependent on meth use. However, if you're driving a long-haul truck under the influence, you're putting your life at risk and the lives of others. What would happen if you crashed your car and you killed a family? I hear you saying that your drug use is, dependent, or your livelihood is dependent on ongoing drug use. Well, your parole officer is going to put you in prison. That's a negative consequence. Or the state will take away your children. That's a negative consequence. So it's trying to say, well, look, I hear what you're saying, but there are these negative effects. You're not taking your HIV therapy. Your body's falling apart. Your teeth are rotting in your head. Look at these negative consequences. Can we find something else to take the place of methamphetamines so that you can still continue to have a life that you want to live? But that becomes more important. We don't want to get into an argument just about whether or not their claim is valid. From their point of view, it's a valid claim, so fine, have that claim. But let's look at what's happening in your life, right? Let's look at the consequences. And that's something that drug use often hides, are the consequences of behaviors. And so it becomes really important for someone who's pre-contemplative or in denial is to try and help that person see that there really are consequences to their actions. Another question that was asked is, what have you found to be the most effective in addressing methamphetamine cravings? Do you use anything pharmacological for these? So my best bet would be what has been shown to be effective in cocaine use. So both methamphetamines and cocaine raise dopamine in the nucleus accumbens, and that causes this amazingly wonderful feeling, right? Which drives people to keep going back to that feeling. And so what they found in cocaine is that if you give disulfiram or antabuse, 250 milligrams, that will raise the dopamine in the brain. And there wind up being kind of two groups of people. There are people that inherently have what we'll call normal dopamine levels. And then there's a group that has a lower dopamine level. Now, the people that have lower dopamine tend to have more craving. They tend also to be more liable to become addicted because in many ways that, and their addiction is a complicated thing. It's not just biological. There are a lot of environmental factors and social factors. But one biological factor is if your tank is around half empty and you take something that raises you to a full tank, you like that feeling and you want more of it. So what they found in cocaine use is if you give somebody the disulfiram, it raises you up to kind of a normal level. Then you use cocaine, that cocaine becomes dysphoric. You don't use as much, you don't like it as much. The big problem is what? You just stop taking the disulfiram because you'd rather have the cocaine. So adherence becomes a huge issue. There have been a bunch of randomized controlled trials on this. The best effects have been when the patient's on methadone and you're giving disulfiram at the same time you give them methadone. So methadone's good adherence. You get good adherence with the disulfiram, you tend to see cocaine use go down. We've done that in our clinic before. It is effective. It has not been looked at so much in methamphetamine use, but the biologies should be relatively the same. Someone's asking, when I get patients back from an inpatient 2-week therapy group, the provider in the facility would put the patient on Zoloft. Why? Well, one possibility is that they're going based on an earlier slide I presented, where sertraline had been tried for the treatment of methamphetamine abuse. That study ultimately showed that it's not effective in the long term. One other possibility is that a lot of the patients wind up having depression. So one of the things that either happens, either leading someone to use drugs, is depression and what's called the self-medication hypothesis. I'm depressed, I want to feel better. Drugs make me feel better, I use drugs. When I stop using drugs, I feel miserable again. And so the Zoloft might be a way to try and say, let me help you not feel so bad. Right, so that's one possibility. Sometimes also people aren't depressed, they start using drugs because of some desire to have a novel experience, or back to the chemsex conversation, to make sex better. And so people start to feel a situational depression. They start to feel bad about all the things that they have done as a result of using drugs. The damage they've done to their bodies, the damage to relationships, the lying to people, all the things that happen. And so people can become depressed as a result of drug use. So it could predate drugs, or it could be after drugs. For those who claim they use meth to treat their poor concentration ADD symptoms and got addicted, what is your approach? Can you justify for a controlled stimulant such as Adderall use in a controlled setting if a patient is adherent? Well, so certainly we want to take a patient. It's each patient is himself or herself an individual, and so we have to look at that person. I always believe firmly in an individualized treatment plan. So in the grand scheme of the world, using methamphetamines to treat ADD is not a common thing, right? So it's like my patient saying, I only started using heroin because I had back pain. Okay, yeah, I mean, gram for gram, heroin is a better pain reliever than morphine, but that's not the normal response to chronic pain, right? Maybe it's eating too much ibuprofen, maybe it's drinking an extra glass of wine or something, but going out and buying heroin tends to be a whole different state of affairs. So one of the most important things for that patient is going to be a good family and social history. So for example, if that patient were to say, yeah, I drank too much when I was in high school, I experimented with cannabis and other stuff, that's going to start to get you a little bit concerned that this is the kind of person that is struggling with substance use and has struggled with other substances for a long period of time, and maybe someone that a stimulant like Adderall is not a good risk for. Or you may find that that this person's first use was with methamphetamines for whatever reason. A friend handed it to him and said, "Oh, look, you can't concentrate in college. Take this, maybe things will get better." But then you find out, oh, his mother has a drinking problem, or his dad had a problem, or some uncle. So again, that family history becomes really important, and also kind of some of the just socially unstabilizing things of like, has he been in trouble with the law? Has he had car accidents, which would suggest drunk driving? Are there other things to give you a heads up? But in the setting where you say, well, gosh, you know what, look, I've weighed the risk and the benefits. I think that the patient could potentially really actually benefit from this. Then absolutely, there may be a justifiable reason. Then it comes around to, well, how do I support that adherence? How do I prevent the person from going off the rails? So then I may say, okay, and in our pain clinic, we've treated people with opioid use disorder on methadone maintenance, and we've treated them for chronic pain, say an HIV peripheral-neuropathy, chronic back pain, or something else. And so you might find somebody who's on methadone and on oxycodone or on a fentanyl patch. And so you're treating two different things, right? So, but in those situations, we have lots of other structures. So you're coming in more frequently, we're doing urine toxicology, we may have to do a pill count. So in this situation, it would be look, I totally get it, but you're admitting you got addicted to a stimulant. We're gonna try this, but I need to see you every week, or I'm gonna see you every other week, but we're gonna need to call you in for random urines or whatever. However you structure it, it should be an open conversation with the patient. It should be detailed in a patient agreement, just so that everyone's on the same page and the patient really feels like he or she's being heard. Any thoughts on naltrexone, particularly those without comorbid alcohol use disorder or opioid use disorder? So naltrexone has been looked at in stimulant abuse, has not been found to be overly beneficial. Certainly in somebody who also has an alcohol use disorder, I would absolutely want to use naltrexone. Naltrexone is still the best medication we have for alcohol use disorder. What's your experience using weight loss meds for patients with obesity and a stimulant use disorder? Weight loss is sometimes identified as a trigger to use meth by my patients. Have used them successfully? No, I have not used weight loss medications for patients with obesity and stimulant use disorder. By the time people come to me, actually, they tend to be underweight as a result of protracted use. One individual is saying, I typically use Vyvanse rather than Adderall in these folks as it is a prodrug and therefore does not provide the high that snorting or shooting Adderall does. Absolutely. Absolutely. Good point. Another individual says, some training I've been to say after stopping meth, it takes 1.5 years for them to feel normal again. When I saw in your neurological changes, does that apply? When people quit using meth, they feel terrible. Do you find SSRIs help people feel better when they quit? If there is anything you use pharmacologically to make people feel better when they quit? So yeah, there is very limited data, but the data that we do have is that, at least on PET scans, the dopamine that we saw that wanes takes about 14 months or so to come back, right? So it's hopeful that the brain can get better. Now, in people with HIV, it's not entirely clear that it does get back to normal. Because HIV does something neurocognitively, and so does methamphetamines, and there is some data that those changes might be permanent, which is, I think, one of the additional urgencies with trying to get people who use HIV or have HIV and use methamphetamines off those methamphetamines. So there isn't actually a standard medication regimen to use when people are coming off stimulants to try and help them feel better. A lot of people use SSRIs. I don't think there's any, I mean, assuming that the person does not have suicidality or their contraindications to an SSRI, I think an SSRI is completely a reasonable thing. Remember that antidepressants like SSRIs have a huge placebo rate. So they still do randomized control, double-blind placebo-controlled trials for antidepressants because 40% of people diagnosed with major depressive disorder by a psychiatrist using DSM criteria, 40% of individuals are going to get better with the placebo, right? Which is unbelievable. So if you're going to use the SSRI, talk it up. You know, really encourage the patient saying that this, I really think this is going to be helpful, because if the person really believes it, there's a higher probability that it's actually going to do something helpful. One of the most important things is actually going to be continued contact with you as a provider. So you got to remember, a substance user is not going to have a lot of sober friends. They may or may not want to go to NA communities. They may or may not want to go to church or religious institution and find sober people, right? I mean, that's key. Think about it. The greatest risk to relapse for an individual, part of it's feeling crummy, but part of it's any stress at all. Your rent's due, you lose your job, your partner leaves you, any stress is going to push you back into drug use. You need somebody in your world who can speak into that, who can say, no, man, let's go out, let's go for a run, let's go for a walk, let's talk about it. You don't need to go to drugs, right? So checking in frequently with you, with a social worker, with somebody that they trust who can be a voice of reason is incredibly helpful. Don't underestimate the power that you have as a provider and being a sympathetic ear to help effectuate change for your patients. So I have a patient who has been inpatient treated several times, children taken away. She's done her time, so she's gone to prison. She has a negative hair and urine, and judge made her wear a patch. And she has shown to be positive. The only med she is on is the ART. Her hair and urine is negative. Now what? So I would wonder what the patch is. If that's, they do have a sweat test. So I don't know if that's what's going on. And I would want to get it validated too. So there are multiple tests, right? So you can do an immunoassay. An immunoassay is what I used to liken to the old ultrasounds, right? Where it's kind of fuzzy and you kind of have an idea of what's going on. So an immunoassay can be fooled. We had an old immunoassay that patients on generic Zoloft would wind up turning benzodiazepine positive on the urine test. We would have to send it out for confirmation, and then it would come back negative. So the kind of gold standard test is a gas chromatography mass spectroscopy. So if it kind of depends, right? So if you've got the hair test and the urine test that were GC mass spec, and you've got a patch test that was an immunoassay, I'd say you throw out the immunoassay. It really sounds like the judge is out to get her, and she needs a better attorney, because unfortunately, our criminal justice system can still be very punitive towards drug users and unforgiving. And I think that's also something that pushes people into continued use, is for this, if this woman is working her tail off to try and get her kids back, to try and be a, rejoin civil society, and yet criminal justice keeps saying, you're unworthy, we don't forgive you, then at some point, what's her motivation, right? And she may just give up. Other questions? I'm sorry, I've lost track of time here. Oh, we've got 20 minutes. One of the most important things, as you're working with your patients, obviously you're all the concerned individuals with your methamphetamine users, but make sure to encourage your colleagues. I continue to be amazed at the number of people who forget the humanity of drug users. And I think sometimes that's the fear that everyone has, that addiction is almost a contagious disease. But make sure, drug users are people too. They deserve respect. They deserve dignity, just like people with HIV do. But people with HIV who use drugs are a particularly marginalized group of people. So someone asked a great question. Any experience with contingency management and methamphetamine use? So most of the contingency management work that's been done in the Northeast has been done with cocaine use. Contingency management does work. What tends to, I guess, frustrate people is the conceptualizing the idea that you're paying someone to be sober, which many people find not to be, I guess, to find morally reprehensible. I don't agree with that position, but it is useful. The issue is getting funding to do it, because policymakers don't feel like they should have to pay people to be sober. It can be very difficult outside of NIH funding to, in a study, to get money to do that. Another individual writes, this may be just an anecdote, but if you can weigh in, I have a patient who uses meth, but also claims anxiety and wants clonazepam. He doesn't necessarily have aberrant behavior on clonazepam. He never asked for it early. It's not daily use. He has argued for harm reduction. I've decided not to give it to him because of my experience with the Board of Medicine. I guess it's hard to say if his anxiety is from meth or if he really has anxiety. So so in this situation, I think it's a really important question, because patients will often want to come in, and so the street benzodiazepine use really took off as a way to moderate the negative consequences that occur as a result of the side effects of drug use. So for example, it used to be that people would just drink a fifth of vodka, right? It does the same thing. It's going to calm you down. It's going to take you down from all of the side effects of meth or coke. But the big problem with alcohol, aside from the fact that it causes liver damage, which our patients may or may not be thinking about, is the fact that, well, if the cops smell it on your breath, you can be drunk and disorderly. And also, it leaves you with a horrible hangover, right? Xanax doesn't do that. It works faster, no side effects, no hangover. And if the cops come by and smell your breath, you're just, maybe you're annoying, but you're not intoxicated walking around the New Haven Green. So I would agree with not giving clonazepam, partly because I would be concerned that it's enabling the behavior. The person might be able to use more. So in that context, I would just say to the patient, I can't determine whether or not your methamphetamine use is driving your anxiety, or if you have anxiety underlying. Let's find a medication that helps anxiety that's not going to, this, like clonazepam, ultimately potentially addictive. You've got one problem, let's not create two problems. So let's try something else that treats anxiety, right? And the patient who's really concerned about help for anxiety tends to be open to trying a non-benzodiazepine. the person who's like, no, only only clonazepam works, 1 milligram TID. I need brand name only. Those tend to be red flags that tell you this is something else. So yes, methamphetamine can be laced with other substances. Right now, cocaine is the stimulant that has the greatest probability to be laced with substances, simply because there's a global cocaine shortage. Never thought I'd say that. So cocaine is being laced with all kinds of things, some of which can actually cause vasculitis-like syndrome. So I would definitely be concerned about lacing with methamphetamines. Remember, the reason the drugs are laced is basically to increase the dealer's profit margin. So if I've got, I don't know, 100 milligrams, 100 grams, whatever of methamphetamine, I could turn that 100 into 1,000 by just adding junk in it. But I'm charging the same as though I was charging the 100. So I've increased my profits by tenfold. One in question is, have higher rates of sexually acquired hepatitis C been found among methamphetamine users? So that's a really interesting question. I don't know that that's actually specifically been looked for. So I'll check that out and hopefully have an answer when we talk about methamphetamines and HIV again on Tuesday. We do know that, so if I were to speculate, I would say we know that MSM is an area where we have high rates of hepatitis C relative to sexual transmission. And so there would be a concern that people doing chemsex fueled by methamphetamines might have a greater probability of getting hepatitis C. We do know that the injection of any drug increases the probability that you would get hepatitis C. For an HIV patient who is, and Donna is reminding us that you can, as I had said when we started, absolutely you can unmute yourself, ask your question however you want. This is a dialogue. So for an HIV patient who is psychotic due to meth use, pre-contemplative to evaluated by psych, comes in weekly for ARV dosing, but not always, so he misses an average of 2 to 3 doses a week. Frequent meds being stolen. Wow, now for the past 2 to 3 years. How comfortable do you feel about continuing his ARV, or is it better to hold ARV given this status? Wow. Well, if the person's actively psychotic, I would wonder if, if it was a threat to himself or others, if he could be hospitalized. Someone who's actively psychotic is someone we could paper in New England and send to the hospital, try to work with the hospital to get enough of the stimulant out of the person, get them calmed down to try and get them stabilized in an inpatient environment. Assuming that nobody's willing to paper this individual and that this continues, yeah, I would, I don't know. I think the one question would be, if you can get labs on this person, how's this person doing immunologically? I'm always really reluctant to stop therapy on anybody. So I would, yeah, I think it's a case that we'd have to talk about some more. One individual has contributed that I find that Hep A is high in MSM users. We do know that there has actually been an outbreak of hepatitis A among drug users nationally, and the CDC has been working to actually increase hepatitis A vaccination among drug users, and that should be something certainly that we're all doing for our patients with HIV. Another individual says, I have an HIV patient who uses meth who loses his ARVs also. Can meth cause long-term psychosis, or is it only when the user is high? So we believe methamphetamine can cause long-term problems. Stimulants can cause psychotic breaks, actually so can cannabinoids. And typically, certainly for cannabinoids, when you have a psychotic break, that tends to result in permanent psychosis. People who tend to have psychosis with stimulants, some can get better and some wind up having long-term after effects. The mechanisms by which they're causing psychosis is different. Cannabinoids, I'm more concerned about a long-term psychotic issue than stimulants. It's not an advertisement for stimulants by any way, I mean. Other questions or comments? Comments that people listening want to make on some of the things in the chat that people have asked questions about or talked about?
I have a question, another question. Can meth be used as an aphrodisiac? Is that the right word? Or
Yeah,
go ahead.
Go ahead, finish, sorry.
Well, they have told me that they've used it on their genitals, I guess, to get, I know, to get a higher, higher high. And I'm going, well, I've never heard that one. So I didn't know if anybody else had heard that.
That's interesting. I mean, some drugs people will insert rectally because there's a lot of veins there and you can get rapid absorption. And so some people will like to do that. Many of these drugs can be absorbed through the skin. And so they may be getting some form of pleasure from that. Ultimately, I mean, part of the issue with drug use and sex is that people report that it actually increases pleasure. Part of that's likely because the medication is, so when I say medication, the methamphetamine, what it does is it's actually working on the part of the brain that actually causes orgasm, right? So you kind of, you could think about it like it's helping you peak earlier, maybe better. Certainly lots of people will compare drug use to actual sex. And so a lot of people will use drugs, especially stimulants in the context of sex. Some people will also say it lets them go longer, which is the market for Viagra and ratanavir for those who still can get it.
Can I branch off and ask more about that? A lot of my young MSM patients are coming in with concurrent methamphetamine use, asking for agents like Viagra, Cialis, erectile dysfunction medications. What experience, I guess, would you say that you've had with that situation, and how would you navigate prescribing or not prescribing those type of medications to the concurrent methamphetamine use?
It's a great question. So one of the things, I mean, people may be a little bit more progressive now than they used to be when we were concerned, certainly in New England, even about people being prosecuted if you transmitted HIV. So we would always have to have conversations with people about, look, you have to understand the risk that you're taking and the risk that you're putting other people under. I think that one of the things that you worry about is enabling behaviors, right? But at the same time, you don't want to be in the position to get into a wrestling match with a patient, right? So, but I worry about enabling behaviors. Enabling behaviors are behaviors that you as a provider do that actually helps support and or foster the drug use of the patient. An example would be, I'm giving oxycodone to a patient and the patient takes oxycodone and then winds up selling that oxycodone for methamphetamine or for cocaine or something, right? So that would be one obvious concern. So in your context, I would be concerned that if the motivation is around mixing drugs and sex and I'm giving the person something to prolong sex, I may increase their drug use or prolong their drug use. And so that would be something that I would be concerned about. So that's something to, if you can have that open conversation with the patient, to have it. What tends to happen, I think what a better policy tends to be is one that's a clinic-wide policy. So it's the clinicians getting together saying, okay, well, what do we want to do as a clinic? Because in those kinds of situations, it becomes very helpful to be able to say, I'm sorry, I can prescribe 3 of these a month, or I can't prescribe any, or I'm not supposed to prescribe these when you have a methamphetamine positive urine toxicology or something like that. So when it's not about what you're doing to the person, about what is our policy, that becomes very, very helpful. So when I would talk to patients about, well, we're on these pain meds and you popped up as, having a stimulant, I have to get you to a drug program. Oh, well, Dr. Bruce, we're friends, it's a one-time thing. For me to be able to say, hey, look, yeah, we're friends, I totally get it, but it's the clinic policy. I wouldn't tell the patients that I made the clinic policy, right? But I'd say, look, I'm sorry, that's the policy. This is what we got to do. And that became then, it's not me versus the patient. It's, we both can be mad at the clinic policy. It sucks. I'm sorry that the clinic does it. But how can I help you? What are the other things that we could do to try and help you out? Someone else asked, I heard one speaker say that the experience of having sex on meth is so astronomically higher than without, that part of the conversation about stopping meth is preparing people for the fact that sex will be less pleasurable. I think that's a great point. It's a great point. Or maybe it's also telling people they have to be a little bit more creative in sex. Another person says, with some of my patients, it seems they fall into a cycle. They can't enjoy sex without meth. They can't do meth without sex. I think that certainly really kind of creates the cycle that's been discussed. Neurobiologically, the two are linked. Behaviorally, the two become linked. It becomes very difficult. Another way to think about this is oftentimes individuals who have a long-term relationship, they met over drugs, they've been having sex and doing drugs together. When one tries to get sober, the other can't, like, you can't be half sober. Both of you got to get sober or nobody gets sober, or you have to leave that person. And sometimes even when they both get sober, if their whole relationship was based on drug use and sex together, they don't know how to be a couple apart from that. And then they can wind up sabotaging each other's sobriety because, well, sex was more fun with you when you were high. And so it becomes very difficult for couples in those situations as well. An anecdote, I had a patient that I found on exam had indentations in the lower aspect of his tongues. That was when he chose to tell me that he was using meth on the weekends. And when he is coming down from it in preparation for the work week, he sucks on his tongue. That's interesting. I thought you were going to say that he had amyloidosis, right? And his tongue had gotten larger, and that's why I was biting his teeth. But that's very interesting. People will, I think, in this vein, people will wind up engaging in compulsive behaviors. Stimulants will often do that. So it certainly will exacerbate OCD or other things where people will wind up doing repetitive behaviors. Also, for the patient we discussed earlier, apparently that patient had AIDS, CD4 count less than 50, was on Biktarvy for 1 month with some viral load suppression, and but now not consistent with Biktarvy, refuses to take prophylaxis for toxo, pneumo, concern for resistance. Would long-acting Cabral and Repulverine be an option in the future? I think definitely long-acting medications are something a lot of us who take care of drug users have really been looking forward to, because it's something that actually provides people with the medication that they need in order that they can have the immunological benefits while trying to address the adherence issue. The big key, though, for the long-acting agents is going to be making sure that that person comes back on time. And so one of the things that I found is that it can be very helpful to have those appointments earlier rather than later, right? So let's say you're supposed to come back and see me in 2 months. I might bring you back instead of at 8 weeks, at 6 weeks, thinking that, you're going to wind up somewhere between 6 and 8 weeks. Hopefully you'll show up. I'm also making sure that you have updated contact information. Our patients, the phone numbers change like constantly. And so it's very difficult sometimes to make sure that you can reach the person. So what we'll also do is make sure that we have some idea of, well, where does this person hang out? Do you hang out on certain street corners in certain neighborhoods? If I can't reach you and one of the Ryan White case managers goes out to check on you, where's a good place that we're likely to find you? Again, trying to make contact so we can help and support you. And patients tend to be pretty open about, in New Haven, be like, I hang out at the McDonald's at Ferry and Grand. Okay, I know where that is. That's a hot spot, right? Not just for Big Macs. Another individual says, I do find that with meth more than other drugs, my patients incorporate into their lives. They use it to go to work. They use it to have sex. They're very dependent, and they're still able to have jobs, and that makes it very difficult to quit. Absolutely. One of the things that methamphetamine has over against cocaine, for example, is there's a very long half-life. So you could take a dose in the morning, and that'll get you through your whole workday, which is very different than cocaine. You take cocaine, and then you're going to get 30 minutes out of it, right? So it's one of the reasons that in like areas like, New England, New York, there's a lot more cocaine use, simply because if you're a drug dealer, it's a better market, right? You got to buy a bunch more cocaine from me today to make it through the day high. You'd have to buy just a lot less methamphetamine. So to the point, you could take 1 or 2 hits a day on meth and kind of be a functional user, if there is such a thing. And that functional use would be, I'm taking in the morning, I kind of get through my day. And then it winds up where people start equating it to coffee, right? Well, it does take a little bit, it helps me be more productive. And so trying to help people understand, and I've used graphic sometimes. Like I've shown people pictures of PET scans and things. Look, yeah, look, that's, you know, show your patients that picture of a methamphetamine addicted brain and the Alzheimer's brain. You know, nobody wants a brain that looks like Alzheimer's. People are going to be afraid of things like that. And it's not, again, trying to be a shock therapy, like, you know, the fried egg on the pan, you know, this is your brain on drugs. It's really a, well, let's look at the consequences. I mean, like, I'm concerned about you. How do I help you? I know you're thinking that there are no consequences. Again, that's an earlier thing we talked about. In drug use, you feel like there are no consequences to my behaviors. And so one of the big things is trying to help educate people. There are consequences to behaviors. Let's look at some of those consequences. And so helping people understand that begins to lay the foundation. And sometimes that's a foundation that's going to take a year or 2 years to bear fruit, but it's the start. And that becomes really important for our patients. Have you had problems getting disulfiram covered for cocaine methamphetamine cravings? I have not, but that's just in Connecticut, Medicaid pays for all kinds of things. And so it's been relatively easy to get it covered. So I'm not sure in what area of the country you're writing from. I would give it a whirl. It's also really cheap. The big thing obviously is patients can't drink alcohol on it. The data is because disulfiram lasts a long time, probably don't even have to take it every day. Probably have to take it 3 times a week, kind of like you would Bactrim for PCP prophylaxis or PJP prophylaxis. Someone's asking with meth for most, eventually there is a slide from use to misuse. Absolutely, the effects start to take over a person's life. More and more time is spent acquiring and using the drug. Our job is to help our patients see and accept us. Absolutely. That's part of helping in the individual who's pre-contemplative, who says things are fine, there are no consequences. That's helping that person start to see, and that can be the conversation. You know, well, when I talk to you, the only thing you want to talk to me about is methamphetamines. Or is this the only thing that's important in your life? Or how are things with your partner? Oh, things are miserable. What I don't spend time with my partner. Well, why not? Or I was late for work. It's starting to show the negative consequences to drug use that begins to open people's eyes to the fact that there are consequences for behavior. And I know that sounds kind of ridiculous. How can a substance user not realize that there are consequences? But think about the behaviors, the things that they're doing. They're acting as though I'm taking an addictive substance, but I won't get addicted. I'm taking an illegal substance, but I won't get in trouble with the law. I'm taking a substance that could hurt me, but there will be no consequences. People are behaving as though there are no consequences to their actions, and that's something that we have to, over time, patiently help people understand. So regarding Hep A transmission, it's important to do harm reduction counseling with a patient about sharing needles, booty bumping, absolutely. So when we talk about harm reduction, just so everyone's on the same page, we're talking about meeting an individual where he or she is at. So, and not making any presumptions based upon what the person knows or what the person does, and not making judgments relative to that. When an individual feels judged about a behavior, that person is now not going to tell you anything about that behavior. An example of that was a patient that I took care of. Kind of, you're in the academic environment, I get handed a patient who'd been seeing somebody else for years and years, and get to know the guy. And over time, he actually starts talking to me about his own obsession with going to glory holes and engaging in oral sex with random individuals. And he had not felt that he could talk to an HIV provider about that because he felt judged, right? And so again, everyone's entitled to your opinion about whether a behavior is right or wrong. What's critically important as a healthcare provider is that we don't bring that personal judgment into the room, but we allow individuals to share their experience and to educate us, so that, I've had patients in the leather community educate me about things that I had absolutely no understanding of. And part of it's just asking questions and saying, well, yeah, you've used a word, I don't know what it means. Could you teach me about it? Or, so what's going on? And then breaking it down and talking about, as regarding Hep A transmission or other transmissions, just to say, okay, well, I understand this is what you're doing. I understand why you're doing it. These are the risks. Let me help you understand the risks. Let's think about ways to reduce your risk so that any negative consequences are minimized. Can I turn your meth Alzheimer's disease brain slide into a poster to hang in my exam room? Absolutely. The slide's not mine. There should be a citation at the bottom, so just make sure the citation is visible, but absolutely. I found visual aids to be super helpful in talking to our patients, especially when I think sometimes patients just assume that I'm making it up, like, of course drugs are bad, but I feel fine. But then showing people a visual aid is actually incredibly helpful. We've got about 7 or 8 more minutes. I want to thank everybody for being such a lively group and chiming in both on the chat and verbally. I had no idea what to expect. My greatest fear was that it would be me and the technical support guys listening to each other. I believe all of these are also being recorded, and again, the slides will be available. We'll talk more on Wednesday in the opioid and pain conversation. We'll touch a little bit on some of the neurobiology of addiction, which will also, I think, be helpful in the context of this conversation. Is there specific training you would recommend for a therapist working with methamphetamine users? Yes, so motivational interviewing and CBT are really, really great. I think everybody in HIV care should know and learn and like sleep with, breathe, eat, motivational interviewing. MI is a wonderful way to engage individuals. It helps you as you think about whether your patient's pre-contemplative, contemplative, and whatever stage of change they're in. It really helps you interact with that person in a non-judgmental way. One of my favorite things is the roll with resistance, right? When your patients are pushing back, it's kind of, it's like improv comedy, right? You just say, yes, and let's move on to the next thing. So motivational interviewing, it's something that anybody can learn. I encourage everybody to learn it. CBT is really helpful. I will tell you that in the studies that have been conducted looking at what's the best kind of therapy, really it winds up being the therapy the patient is willing to engage in and will participate in. So whether that's NA, so Narcotics Anonymous, whether that's being a methamphetamine user not wanting to go to NA but willing to go to AA, whether it's CBT. There's one form of therapy, dialectical behavioral therapy, which is important for borderline personality disorder. But other than that, it's really about finding something the person is willing to accept and participate in. And part of that, and one of the reasons that I encourage people also to think about an AA or an NA community is because people need community. I mean, our patients need sober friends. There was a study done using Remeron to help reduce meth cravings. I found it to be helpful in some. One of the individuals wrote in, absolutely, there was some data on that. Again, it was a small study, looked good in smaller groups, didn't look so good in a large group study. But again, one of the things is that a lot of these medications, whether it is a placebo effect or a true effect, if it's helpful to your patients, absolutely. You always have to balance the risks and liabilities with the benefits. So just as we wrap up, I'll tell you one additional anecdote. I had a patient years ago. This is an opioid user, but I think it still fits the same bill. And that was that this individual, he was kind of famous in drug using terms. He knew generations of correctional officers. He'd been using drugs forever. And when in the early days of buprenorphine, we were trying to get people on buprenorphine, and no one wanted buprenorphine. Everyone thought, it was some crazy Yale experiment or something. And so nobody wanted to participate in it. And eventually this guy shows up at the HIV clinic one day. He'd just gotten out of jail. He shows up in clinic, and I was in clinic, but I was just there charting. And he comes to the front desk and is like, I got to get on this buprenorphine thing. Like, I got to get on this thing or I'm going to relapse. And it was a Friday. Nobody knew what to do. Somebody found me and I was like, oh, okay, try him on Suboxone. Let's give it a whirl. And he actually wound up getting sober, doing CBT, became kind of the model citizen, was in trouble with the Department of Children's and Families, with probation, like with everybody, and wound up having a protracted sobriety. And I think the two interesting anecdotes from that were, number one, he was so well known in the drug using community that people would start coming up asking for them. Can I have that medication that Keith got? Because like no one thought he'd get sober, but he got sober. And the second thing was that eventually he was doing so well that he transferred out of my care to another provider. And, you know, he kind of, I guess, felt guilty or something that he was leaving me to go to another provider. And I was like, no, you gotta be kidding me. This is like the most amazing and wonderful thing in the world, right? You're going on with your life. And I think that's my hope for everyone here, is that, you know, sometimes the patients that you think are hopeless, don't give up. Maybe that's the one person actually that by interacting with and supporting might actually be the person whose life gets changed. And my thanks to everyone who has been taking care of people with HIV who use drugs. It is a challenging population. It requires incredible patience and perseverance. You all have my respect for doing that. Thank you all so much, and enjoy the rest of the conference today and this week. Thank you all.